Welcome to all of you who are entering the Colorado Cancer Coalition's lunchtime webinar about all things COVID. So we're almost up to 60 people, so we'll just see where we sit at a reasonable amount and we'll get started for today. So if everybody wants to take a minute, if you have a moment to write your name, your organization, and which city or town you're from, that would be much appreciated. So just give us a little bit of chance to see who's all on the line today. So can we get a 65? Can we get a 65? I feel like an auctioneer right now. We're at 65. All right, perfect. Okay, everybody, it's right 1 minute after the 12 o'clock hour. So I want to say a huge thank you for everyone who's in attendance today. I know we had well over 100 registrants, with several folks saying they couldn't attend live but are excited about the recording. So thanks so much for joining. Hi, I'm Andy Dwyer from the University of Colorado Cancer Center, the School of Public Health, and I am this year's chair for the Colorado Cancer Coalition. So I want to say a huge thanks to all of the attendees. If you can go ahead and write your name, organization, what part of the state you're from, and town, that would be great to have all of you on. I'm delighted that we're going to have Dr. Chris Liu and Dr. Mark Ernest sharing today perspective around specific around the COVID vaccination, the impact of COVID-19 in Colorado, and the future trajectory for COVID vaccinations, as well as just thinking about really where we are in terms of a chronic disease group, cancer survivors, and then those of you who are working in the medical field and community and public health as well. So we will hear from Dr. Christopher Luce, who is an oncologist with me at the University of Colorado, and also Dr. Ernest, who's going to be sharing from internal medicine from CU, also sharing some perspective about the general chronic disease survivors, and really thinking about what does COVID-19 and impact in the chronic disease sphere for people who are survivors, and also thinking of prevention as it relates to COVID. Just a quick note, Christy Cahill is joining us today. She is not on camera, but she's been fantastic in terms of supporting these initiatives. And a reminder that the Colorado Coalition website has a number of resources available and has actually put forth language and information to the governor's office, further sharing the support of making sure that vaccines are readily available for cancer survivors in the cancer community. So with that, I'm going to turn it over to Dr. Liu, who will begin sharing some perspective, and then we'll have Dr. Ernest sharing as well. We'll have plenty of times for questions, comments. Make sure and use that chat feature today. So there is a chat. Ask questions real time. We'll try to interject as much as we can and have plenty of questions at the end as well. So we're now up to 80 participants. So Chris, I'm going to turn it over to you.
All right, well, thank you everybody for taking time out of your day to join. And on behalf of Dr. Ernest and myself, hopefully you'll find the information that we present here to be helpful. And so, I'm gonna try to go through several of these slides fairly quickly, because I believe a lot of this is information that you all know and have seen and been unfortunately inundated with through the news and through various media sources. But we're going to go through a quick update on COVID-19 and how we're doing in the state of Colorado. We'll give you a quick update on how COVID-19 has impacted UC Health. And so I think it'll be good to get a little bit kind of a hospital level data on how the COVID-19 pandemic has impacted the hospital system. And then really we're going to get down to the meat of what we want to talk about over the next hour, and that is, of course, the COVID-19 vaccination. And again, I'm going to go through this fairly quickly because I want to get you to Dr. Ernest, where you're going to get most of your information today. So COVID-19 in Colorado, I've shown these graphs, with the coalition before, but I do think it really is important to look back at what the 1918 flu looked like and how that relates to kind of what we're dealing with right now. So when you look at Philadelphia on this graph on the left, you see that social distancing interventions were enacted very late, and therefore you saw this incredible spike in the number of people dying from the 1918 flu. And of course, that also represents a mass kind of overwhelming of the hospital resources in Philadelphia at that time. And compare that to St. Louis, which enacted these social distancing measures early. And there are kind of two take-home messages beyond just the kind of high peak you see with Philadelphia and this kind of flattening of the curve with St. Louis. That's obviously the first take-home point, but of course the second take-home point is that it just lasted a lot longer in St. Louis than it did in Philadelphia because you didn't have that incredible peak. And so when you think about how long we've been in this pandemic, we do mimic St. Louis in this curve as opposed to Philadelphia. And much like St. Louis, which had a spike in November and December, we experienced a similar spike. So what you're looking at here is the Colorado 7-day moving average for COVID positive tests. Now, keep in mind that this curve is directly impacted by the sheer number of tests that are available. So we know that this pandemic was bad in the spring of 2020, but of course the numbers didn't reflect that, and that's because there just wasn't enough testing available. But you can kind of see that we did fairly well over the course of the summer into the early fall, but then when we hit November and December, the numbers spiked dramatically, and you can see how impressive that spike was in late November, early December, but also how impressive that decline has been really over the last month to 6 weeks. And so that's obviously some good news on the side of our state. When you look at COVID-19 deaths in Colorado, and this is just the curve of how many deaths there are over a period of time, you can see that this graph goes from August 2020 and then projected out to May 2021. And you can see again, fairly flat curve as you go from August into November, but then when we hit into November and January, there is a significant increase in the number of deaths that we saw in our state, which is obviously something that we did not want to see. The projection that you see into May 2021 is that you can see that the curve is expected to flatten considerably. And that's really kind of related to, obviously, the decreasing number of cases and also the decreasing amount of patients that we see in our hospitals. So this data shows the Colorado hospital resource use. The purple line shows how many beds are available, which is close to 5,000 in the state of Colorado. The green line and the green dotted line show how many ICU beds are available and how many ICU beds were being used. You can see from the purple dotted line, we never really came close to exceeding the entire hospital capacity, but we did come very close to exceeding ICU bed capacity. And you saw that really heighten towards the end of November and then into early December. But you can see where we are right now, that there are a lot of hospital resources available, and that's obviously a really good sign. If you ever wondered if you were being monitored in terms of social distancing, and this is social distancing as measured by cell phone mobility data, this curve again goes from August 2020 into projected May 2021. You can see that typical mobility, we haven't really come close to that, but that mobility really decreased in the spring, came back in the summer, and then decreased again in the winter. And you can kind of see that the projection is that social mobility will increase some, but we wonder really how long it'll take to go back to any typical mobility from what we saw pre-pandemic. So that gives you a brief overview of where we are in the state. I just want to show you some UC Health data. So UC Health is a hospital system that encompasses a lot of different hospitals across the state of Colorado, but mainly the Front Range. And you can kind of see that this graph represents how many patients were hospitalized within the UC Health system from the start of the pandemic until now. And you can see that we had a really significant spike in the spring of 2020. We had a low of 33 patients in September 2020, but then we had another spike of 469 hospitalized patients in November and December. The hospital census today across the entire UC Health system-wide network is 107, which is a significant decrease, which is really great. So all of this data to show really that there is a light at the end of the tunnel. So within the UC Health system, we had a COVID-19 command center to help us adjust resources and to deal with the ever-changing nature of the pandemic. That command center closed as of February 1st because the numbers have fallen pretty significantly. With the fall in the numbers of our hospitalized patients, we had a slow return to more normal operations, which includes doing more elective procedures. We discussed that we're caring for less than 110 across the entire system. And the overall COVID-19 positivity rate in the hospital system averages 6.6%. That's a little bit higher than the state percentage, which is around 4.8%. And that's mainly because we're also dealing with, obviously, what we would expect to be sicker patients that are needing to be admitted to the hospital. So what we're really here for is to talk about the COVID-19 vaccine. And this is, I'm going to go through this, but you're going to get more information from Andy's discussion with Dr. Ernest. But of course, there are two types of authorized and FDA-approved vaccines, and that is the Pfizer/BioNTech vaccine and the Moderna vaccine. And both of those are messenger RNA vaccines, and we're going to talk about the technology behind them. There are a tremendous amount of vaccines that are being developed across the world in different countries, but the other vaccines that are currently in phase 3 clinical trials are the AstraZeneca, Janssen, and Novavax. But for the purposes of our discussion, we're going to talk about Pfizer and Moderna because those are the currently available vaccines. So, and I know that Dr. Ernest is probably going to talk a little bit more about this, but I want to give a basic gist of how these messenger RNA vaccines work. And so whenever you look at a picture of coronavirus on the news or in the media, it's always surrounded by this thing called a spike protein, which is kind of the outer covering of the coronavirus. And that's why you get the pictures that we see on television. What's interesting is that the scientists can then generate a messenger RNA sequence that codes for the spike protein. It doesn't code for the virus, it just codes for a very small piece of the virus, the outer covering called the spike protein. That RNA sequence can then be kind of wrapped in a lipid coating or essentially a fat coating that allows it to be transitioned into cells. And so you have a messenger RNA vaccine that's then injected into the body. And when it's there, your cells read that information and produce copies of the spike protein. It doesn't produce copies of the virus, just this outer covering called the spike protein. And what's cool about that is that if your body produces that protein, your body can then develop antibodies against that protein, which means that if coronavirus comes into your body, then your immune system will be able to recognize it and fight it effectively. A couple of things that are kind of misconceptions about these vaccines: they cannot give somebody COVID-19. These are not live virus vaccines. This is just messenger RNA that codes for a very specific protein that's harmless in the body. They do not affect and do not interact with our DNA in any way. So the messenger RNA never actually enters the nucleus of the cell, and the cell breaks down and gets rid of the messenger RNA soon after it's finished doing the job that it needs to do. A lot of people wondered how the vaccine actually was produced as quickly as it was. And one of the very, very cool things that I get to talk about in terms of cancer is the fact that we've actually had both the Moderna mRNA vaccine and the BioNTech/Pfizer mRNA vaccine years ago in our cancer clinics, because these vaccines were actually being utilized for cancer care. This idea that you could take messenger RNA from cancer and develop a vaccine. So we were actually giving people these vaccines way before the pandemic ever happened. And so that infrastructure already existed. You just had to change the target and boom, you have an effective vaccine. There is obviously vaccine distribution going on in Colorado, which we're going to talk about more. And so you can kind of see the progress that's been made. And so this is the daily number of vaccines that are being administered. Some days, around 30,000 vaccines have been delivered. This is information as of January 29th, 2021 from CDPHE in terms of kind of the prioritization list for COVID vaccine distribution. And obviously, when you kind of look at the top of this table, you're looking at people who are directly interacting with patients that have COVID-19, and then other healthcare workers and frontline responders. This phase 1B1 also includes people over the age of 70, and that's kind of where we are now. Starting next week, we expect this to go down to 1B2, and you can read here that this is 65 and older, as well as people who are in school, teachers and administration. And then you can kind of see in 1B3 that it includes kind of more what we consider to be essential workers. And you can see here that it's also patients that have 2 or more of these high-risk features. And I'm sure we're going to talk about that, because by this definition, it's not just patients with cancer who are undergoing treatment. You actually have to have 2 of these. So it's not just enough that you're actually undergoing treatment for cancer. You actually have to meet another one of these criteria as well. And as Dr. Ernest will talk about, these are the guidelines that we're currently working under. In terms of cancer, I also want to make sure that people understand that there have been various guidelines that have come out. This is one from the National Comprehensive Cancer Network for patients undergoing treatment for cancer. And the bottom line from this fairly complex table is, if you're receiving therapy, you should receive the vaccine when it's available. The grouping of patients that this may not apply to are patients that are undergoing stem cell transplant, or in a lot of cases, patients that are undergoing highly cytotoxic chemotherapy for, say, acute leukemias. But for the most part, and this represents a vast majority of our patients that are fighting cancer right now, they are recommended to receive the vaccine when available. So how about some more good news? We do appear to have passed our peak of COVID-19 cases. Hospital resources are no longer being stretched. And I will tell you that vaccine distribution is actually going fairly well in Colorado. So, in the ranking of states, Colorado currently ranks 11, which means that we have some room for improvement, but for the most part, we're doing quite well. Interestingly, the states that seem to be doing the best are like North Dakota, West Virginia, and Wyoming. But for the most part, Colorado's vaccine distribution is going. And of course, it's just not going fast enough. We want everybody to be vaccinated tomorrow. But I know that the state and our hospital systems are doing the best that they can. Just a quick note that certainly this has just been an incredibly long pandemic. It's hard to believe that this all kind of started roughly about a year ago, but there are support resources that are available through many, many different organizations, but they are available through the School of Medicine at University of Colorado at Anschutz Medical Campus as well. And so with that, I'll actually turn it over back to Andy and Dr. Ernest, and we'll continue on this conversation.
All right, awesome. So I think there is a question, I think, Mark, you might be able to address it, coming from Gloria, talking about in 1B3, it talks about teachers K through 12, but if there's anything about those in higher education, and I know there's been a lot of discussion about college campuses, so I think, Mark, we might cover that in your discussion, Dr. Ernest. But Dr. Liu, let me just ask you this as we transition. As an oncologist and, talking with patients, I know that you have patients who are super gung-ho, and then you also have patients who are a little scared, nervous about the vaccine. I guess for those people who are working frontline with patients right now in that communication, I guess just sort of with a couple lines or just something that's like a real top of line discussion you have with your patients, how do you describe to patients the risk and the benefit right now as you're talking to your cancer patients?
Yeah, I think that's a wonderful question. And, certainly, and I would say Dr. Ernest will probably say the same thing, that our patients are, for the most part, just wondering when they can get the vaccine. But there are certain patients that understandably have a lot of concern about, vaccines and how safe they are. I would say, first of all, the people that are treating them within the hospital have all received their vaccines and have done well. But when you look at the risks of the vaccine and think about the clinical trials that were involved with the vaccine, where, for the most part, patients tolerated this incredibly well. But then you look at just the sheer numbers of COVID-19 related illness, comorbidities. And what I mean by that is just kind of longer lasting side effects. If you look at the sheer death rate within the United States and even within our own state, the risks of COVID-19 far, far, far outweigh the risks of the vaccine. But in the end, and I'm sure Dr. Ernest will explain this as well, it is a personal choice, but our hope is that we can vaccinate up to 70 to 80% of our patient population to achieve herd immunity, which would be the fastest way to get us to kind of what we expect life to look like, right, post-pandemic.
Okay, great. So Dr. Ernest, I will turn it over to you as we continue our discussion around the dissemination and impact in the population and some additional insight into the vaccine. So Dr. Ernest?
Yeah, so I didn't prepare a long talk. I thought I would just follow Chris and probably not have a whole lot to say because of how thorough he is. But let me just offer a little bit of perspective. One is amid all of the sort of bad news and challenging times of the last year, I just want to call out what an extraordinary thing it is for us to have a vaccine available like this, to have responded so quickly. I mean, literally, I was sitting in a chair getting a vaccine almost, before less than a year before the first case showed up in the United States, and that's just, to me, is just extraordinary. And so, if you need to feel hopeful about humanity, I think this is a good story to kind of hang that need on right now. I will say this, that I am a vaccine booster. I am a complete believer in this. I actually was a subject in the early part of the Moderna trial. And certainly at that point, it was, we had very little information. It was just based on theory. And And I did get placebo, so which I delayed my getting immunized because I had to figure out what role I had in the trial. But I've had both shots of the Moderna trial. I am, my patient population are my average in my practice. Probably the average age of patients in my practice is about 70. Most people have multiple chronic medical conditions, and my goal is to try to get people immunized as quickly as possible. So, and I will say that the data, and Chris alluded to this as well, overwhelmingly positive, both in terms of the efficacy of the trial, of the vaccines themselves, but also the safety. So UC Health has now done, help me out, Dr. Lou, I think we're getting close to 60,000.
I think that's right. Yeah.
With a couple of allergic reactions that were very easy to deal with, it has gone so well that the sort of mandatory waiting has now become optional. So they encourage people to wait 15 minutes after their vaccine, but for people who for whatever reason can't or don't, it's viewed as safe enough that they're no longer requiring that. So again, to lend my voice to the many that are calling for people to get vaccinated, I think the number one thing you can do to protect yourself as well as your family and your neighbors is to get vaccinated when that opportunity comes along. One of the questions that comes up and has come up a lot with my patients is, there are those who are cautious and hesitant. I hear much more often from those who are ready to get a shot in their arm, and it's like, how do I do that? The thing I want everybody to imagine is the reality is everybody's goal is to get these vaccines out absolutely as quickly as possible. So I think there is this sense that there's some, like I think about the fear I used to have of the principal, going to the principal's office. There's somebody back there who's sort of looking and controlling all this. There's none of that. But everybody who's getting these immunizations out there is doing their best to make sense of the prioritization, and then to figure out how do we take the people in the priority categories and get them in line for vaccines. And so each health system or each provider that's doing that has a slightly different way of doing it. So UC Health, where I am, the early part of this has largely gone from us scouring the electronic health record. So it's pretty easy to figure out who's over the age of 70, who has an account through we have a patient portal. And so invitations get sent out that way. It's going to get harder because when we get into to occupation-based categories, because not all that information is in the electronic health record. And so other places are actually, you get on and you sort of sign up, or you just have to kind of, on the honor system indicate what your category is. And then the other thing I would note for people who are, trying to figure out how to get immunized as quickly as possible, it varies a lot depending on like I have a patient who's been waiting to get her invitation from UC Health, who meets a bunch of criteria, who drove this weekend to Bennett to a private pharmacy there and got their shot there. And so I would encourage folks, again, it's doing nobody any good when those vaccines are sitting in freezers unused. And we don't have an efficient way of saying, somebody's waiting in queue here, but there's no queue over there. So the only way really to do that for people is just to pick up the phone, figure out who's, or get on the internet, figure out who's given the shots, and to look and see what the availability is.
Okay, great. So I guess going to we have a slew of questions already coming in. So I think back to the specific question about educators, and I think college campuses have been really interesting to really thinking about COVID containment, as well as what it means for vaccine and kids or young adults really living in such close proximity, and even instructors and teachers and professors. Anything specific about higher ed and whether they fall in that K-12 categorization of educators? Anything to share there, Dr. Liu or Ernest?
Yeah, so as I have a personal stake in this because I've got a sophomore in college and a senior in high school who will be going there. I have not seen higher ed called out in the prioritization, and I think the degree to which higher ed educators get immunized sooner is going to be based on the same conditions as the general population. So as a sort of occupational category, or a student category, I have not seen that called out as a separate priority. Chris, I don't know if you have either.
Yeah, I think it does kind of speak to the fact that, again, I think the intention and the desire is to make sure we obviously get the vaccine to everybody. And we had 300 million doses of the vaccine. I think that's obviously, would be the case. I think that these things, like even the guidelines that I showed you, appear to have changed over time, and we expect them to continue to do so, really based off of need, but mainly availability. So it is something that I know Dr. Ernest and I will be looking at, but as of right now, I'm not aware of any additional guidance with higher ed.
Okay, so Dr. Liu, while you have the floor, we have Julia, who shared that she's a chemo patient. She had the first dose of the Moderna vaccine, had heard that the second shot may result in tougher side effects, such as lower white blood cell count. Should she wait on the second dose? And then there's a follow-up to that, but we'll have you answer that one, Chris.
Yeah, I mean, I think that it's incredibly important to maintain the schedule, right? I think we'll have additional data on how effective one shot is in the future. I don't think we really have that, although there's been, some reports have started to come out. So I think the main thing is that, if you get the first dose, we definitely want you to get the second dose. And the reason being is that we want you to have immunity, but we also want you to have immunity that lasts, right? And we're getting more data in terms of how long that immunity lasts, and that will be coming. The second thing is, the timing around chemotherapy, and nobody really knows the answer to that question. The answer, as you saw for the National Comprehensive Cancer Network, is just to get it, right? If there's a way you can time your chemotherapy so that, you get the dose, before the vaccine, before your next dose of chemotherapy, I think, kind of common sense, that does make sense. But there's really, we give people the flu vaccine, right in the middle of their treatment, even right before we give them chemotherapy. And the main reason being, we're not suppressing your immune system so severely that you're not going to mount an immune response. So definitely do it, definitely get it on time, and I would not let chemotherapy impact that.
Okay, and then the second part of the question and follow-up is that it was read somewhere that someone should wait at least 2 weeks after the second dose to undergo any surgical procedures or anything that may seem, I guess, maybe invasive to the body. Can you comment on this?
Oh yeah, there was another thing about the lower white blood cell count, and I'm not worried about decreasing white blood cell count with with any of the COVID-19 vaccines. And then in regards to surgery, I think there's some guidances out, and Dr. Ernest, you may definitely know more about this than I do, but I think it's actually, they try to recommend not doing the vaccine unless you're 2 weeks after surgery. But I'm not sure that there are any guidances in terms of doing it before. A lot of times, unless it's an emergency procedure, you're going to have some leeway either way. And so if you want to get it a couple of days before the surgery, I can't imagine why that would be a problem. And then I think the recommendation is, if you undergo major operation, to try and get it done at least 2 weeks after that. Mark, are you aware of anything along those lines?
I actually am not aware of that, and I'm not aware of any data to guide that either. But that doesn't mean it's not out there. But
yeah, I think these are all wonderful questions. I think Dr. Ernest and I can really speak to the safety of it. There are always kind of specific examples or specific situations where, what you would love to see is, well, in the 100,000 people where we tested it in this exact scenario, this is what the outcome was. There isn't that kind of granular data, but we can really, really tell you from, really just the sheer number of patients that receive this vaccine that it is safe. The second dose of the vaccine can have some more side effects in terms of muscle aches, maybe a slight fever, but usually those are pretty limited.
Okay. Dr. Lee, you and Mark, Dr. Ernest had both talked about other types of vaccines. So we know right now there's the general flu vaccine, there's pneumonia. We also know, and I think there's a question even about the HPV vaccine. If you use the COVID vaccine in concert with other vaccines, is it effective? It is suggested to use for like the HPV independently, but even how does it work with the flu shot? Is it safe to give all of these at the same time? What do we know about guidance in this area?
The trials were conducted requiring anybody who participated in the trial to have at least 2 weeks separation from any other vaccine and the trial vaccine. So to participate in the Moderna trial, I had to delay my flu vaccine in order to participate in it. So there is this broad recommendation that has continued that says if you're you should try to separate whatever the other vaccine is, influenza, HPV, the shingles vaccine, to put at least 2 weeks between that and the COVID vaccine. I don't think that there is I think the reasons for that are more theoretical than anything else. But what I've been telling my patients is, given the magnitude of the current public health emergency, is with if they're waiting to get their shingles vaccine or whatever, is postpone that until you're through your COVID immunization. So vaccines are preventive, and so we're trying to reduce people's risk. The big risk right now is COVID-19. So if you're up for a vaccine and there's not a prospect of getting immunized in the next couple of weeks, go ahead and get it. But if there's a chance you'll be in line to get a COVID vaccine, I would postpone the other vaccines, not indefinitely, but until you can get the COVID vaccine.
Okay. I see a good head shake from Dr. Liu as well. So it looks like we have great consensus there. So I think going back to the trials and thinking about when the vaccine was going through the trial phase, and I think Dr. Liu, it was great to hear, why we had such trajectory, because I think people have been worried about how fast it came out, but understanding that there was so much foundation, that it was a pivot to be able to test. I think that's really helpful in understanding why we were, and gives probably some real relief to people about how fast, because I think that's come forward. But in this trial design, when you think of folks who had cancer, I think the question coming from Mildred was really around vaccines for people who have multiple comorbidities. So something like MS and cancer, other types of health conditions. Do we know anything about the subset of population? So for instance, MS survivors who maybe were cancer survivors, anything that called out around types of comorbidities and where it would be suggested or contraindicated for the vaccines? Anything that's coming up based on the data that you guys know coming from the trials?
Yeah, I mean, I think additional data will continue. We're going to be inundated with COVID vaccine data in different population. That all that data is going to be coming out. Not to sound like a complete broken record, but I mean, I would say the data from all the trials do suggest, obviously, that the vaccine is incredibly safe. The question largely being, is there going to be a flare of my MS? Is there going to be a worsening of my cancer? Is there going to be some type of risk in terms of that? And the answer is, we have no evidence really to suggest that. I think the only population that's really kind of come out as one that we need to keep an eye on is one where patients have had true anaphylactic reactions, right? And these are just incredibly severe, like admit to the hospital type reactions to these vaccines. I will also make the point that the ingredients within these vaccines are incredibly simple, right? It's not really, I mean, it sounds like kind of space age science, but these are not vaccines that are pumped full of all kinds of bizarre things. It's actually very, very simple, right? We have the messenger RNA encapsulated essentially within lipid, right? Which is kind of like a fat. And then, some things to help stabilize it, like salt and sugar, honestly. So there really isn't anything that's super complex about these vaccines that would elicit these incredibly, terrible allergic reactions. what you're really trying to elicit is essentially the immune reaction, and that's good. If you get the vaccine and your body aches, I mean, I know this is going to sound bizarre, but that's a good sign. It means your body's producing antibodies to exactly what we want it to, what we want, our antibodies to be produced against. And so, even the side effects that you see are just part of the process that is actually, in some bizarre way, kind of reassuring. Mark, anything that you want to add to that?
Yeah, no, the way I think of vaccines is sort of it's push-ups for your immune system. And if you do a lot of push, the more you do, the sorer you get. So so when my arm was sore after that vaccine, that was just my assurance that my immune system was working out. So so yeah, I would encourage people to you're gonna feel you're gonna be able to tell you had a shot at a minimum. I mean, I don't know anybody who hasn't had a little bit of soreness in their arm, and I know a fair number of people who felt fluey the next day, but again, severe reactions have been just vanishingly small. And again, to Dr. Liu's point, these are really clean, vaccines, more so than almost anything we've had historically. That they're very targeted. The sort of idea of collateral impacts it's theoretically very unlikely. To the earlier question about specific populations, so when they set up the trials were, depending on which one you're looking at, 30 to 40,000 people in the trials that were randomized. So 15 to 20,000 people actually received the vaccines. They sampled very intentionally to get diverse populations and to get people who were either at very high risk of exposure or very high risk because of underlying conditions. So almost all the conditions that people have asked about or would want to know about were included in the trial. But the challenge being that you have, so let's say in all those trials, maybe there were 700 or 800 people with multiple sclerosis. The total number of actual cases of COVID as the trials went through the FDA was more around 100 cases. So our ability to tell how different it looks in an MS patient versus somebody else is fairly limited. We're now immunizing millions of people, and as Dr. Liu alluded to, there will be analyses looking at those different populations. But again, I don't think we have any sort of biological reason to be fearful for those folks, and at this point have no practical experience that would indicate that people with particular conditions should be fearful of the vaccine.
And I think on the question about severe allergic reactions in the general population, but I think there's a specific question that what is recommended if severe allergic reactions to heparin and Neulasta are demonstrated, can you take either one of the vaccines? And so is there something specific to those drugs?
Yeah, and Andy, I know that your audio is breaking up just a little bit, but in regards to anaphylactic reactions to other drugs like Neulasta or even heparin, just kind of keep in mind that these drugs, in comparison to the COVID vaccines that we have available, are very, very different. And so just because you have a reaction to one drug doesn't necessarily mean that you're going to have the same reaction to another drug or vaccine in this case. And so I would feel very comfortable offering the COVID vaccine to patients that have had, allergic reactions to, say, Neulasta, just because, again, they work so incredibly different that it's hard to make a comparison between the two.
And Chris, I'm sorry, my question was, can you hear me better now? Is it okay?
Well, you still have a weird little echo.
Very crazy. Christy, can you see the questions and help me just to make sure that it's not?
Yes, I can. Yeah. Can you guys hear me okay?
We can hear you great.
Okay, great. Let me find the next. So there's one on here. How long after having COVID should you wait to get the vaccine?
The current recommendation is 90 days. and I don't know that that's based on really very sound science. I think but that's what the current recommendation is. And Chris, do you know of any sort of science behind that recommendation?
Yeah, I honestly think it's a little bit kind of random or kind of cherry or handpicked kind of out of the air. I do wonder if part of that is that, you know, sometimes you can test positive for a very, very long time, even after you have COVID. But I don't know if that influences some of that decision making. But no, and you know, it's kind of hard to imagine just scientifically, you know, why somebody would react worse to the vaccine, you know, even if they've had COVID kind of more recently. But regardless, you know, Dr. Ernest is correct that that's the current guidance. I guess the good part about that is that, you know, if you had COVID recently, you're likely to also have antibodies. And I'm sure that this is going to come up as a question, you know, and I think we'll address two. Number one, you know, how long does immunity last after you had COVID? And that's, you know, variable, right, for everybody who has had COVID. And so sometimes people can develop fairly longer lasting antibodies. Sometimes people lose those antibodies fairly quickly. And for that reason, obviously, even if you've had COVID, we do recommend the vaccination. And then, you know, one of the questions that came through, Dr. Ernest, was, you know, if you've had the COVID-19 vaccine, can you still spread COVID or get COVID? And I know that was one of the questions that came up in the chat as well.
Yeah, and so here's kind of what we know about that. So I mentioned that I was in a Moderna trial. So every single trial appointment I had, I got one of those swabs up my nose, and that was part of the surveillance. And so in the course of doing those trials, they did determine that there was a subset of people who had been immunized who actually did have PCR positivity from nasal swabs. So the PCR swab, basically what that is any amount of genetic information from the virus, so just incredibly tiny trace amounts show up and are amplified. And so any sort of virus shows up. What we don't really know is practically what that means. So does you know, somebody who has active COVID is actually shedding, we know sheds a lot of virus. Somebody who has been immunized and perhaps has some carriage and some level of reproduction in their upper airway can test positive on PCR, but how likely that is to be able to spread to somebody else. So the advice has been what I think is very conservative, which is to say, if the virus can grow in your nose and you can shed it, then you can give it to somebody else. And so we should all behave that way after we're immunized. From a practical perspective, it's hard for me to imagine that somebody who has a degree of immunity to the virus will shed the virus anywhere remotely like they would if they had the active disease and had not been immunized. So I think you know, and I have this conversation with, you know, patients of mine who are, you know, have grandchildren and are trying to decide if it's safe. And, you know, it's all about moderating risks. And I generally encourage them to say, you know, be safe, be thoughtful. But if it's a difference between seeing your grandkids who you haven't seen in 9 months and not, I'd go hug a grandkid if I were you, because I just think the risks are low.
I couldn't agree more. I you know, just to second what Dr. Ernest said, you know, having a person in the household who's been vaccinated, that's always a step in the right direction. Having multiple people in the same household or within the same family or even extended family that are vaccinated, that's when you start getting to the point where you feel much more comfortable kind of acting kind of how we acted before the pandemic, right? And so that kind of also really stresses the importance of getting as many people vaccinated as possible, because that's the key to kind of returning back to some semblance of, you know, kind of what we are used to doing, right?
Do I sound robot-y or am I better?
No, you're back.
Oh, I'm back. Okay, good. Yeah. So I was going to make a bad joke that I had my first dose of vaccination and that's what happens, but that's not true. So that is not true at all. But I do want to go, because there was a question earlier in the chat before I got bumped off about if the current vaccination regimens are effective against the strains that are coming out and what we know about that. But then I think before we go, this kind of hinges on, I think, the last couple of questions. Does chemotherapy reduce the effectiveness of the vaccine? Might I need to get yet a third shot down the road post-treatment in order to maintain the vaccine and the protection? So in terms of looking at successive booster shots, any idea?
Yeah, for chemotherapy, as of right now, no, there's no recommendation for a third booster, even if you get the vaccine while you're on active treatment. Now, the question that you're really alluding to is, how long are we going to have these antibodies for? And this is where the trial data will continue to be helpful, right? Kind of knowing how long patients have these antibodies and how effective the vaccine is over time. So there is a chance that we may need a booster in the future, or maybe even potentially a better version of the vaccine in the future. But right now, the answer is no. And I think that people can take some comfort in that, but understand that as the virus, and what you're also alluding to is, can the virus change? And I have an opinion on that, but I'll let Dr. Ernest answer that in terms of the vaccine's effectiveness against different strains of coronavirus.
So the data we have on the effectiveness of the vaccine against the strains is very different from the data that we had that got these vaccines approved originally. So, at the point where at least Moderna and Pfizer trials occurred, we really only had one main variant, and so the efficacy was looking at that. One of the new vaccine candidates has actually been tested in multiple countries, and there's some efficacy variation across those countries. And we also have the genetic data, the genetic surveillance data that can show that the prevalence of some of these variants is different. And so if you look at that, it's as much as a 15-17% difference in efficacy in these different countries that is thought to be based on the variants. So I think that the data we have would suggest that that there probably is some variation. Again, this is not looking at Kaiser and the Moderna. This is actually looking, I believe it's AstraZeneca as the one where we have this international data. So I think that sounds really scary, but if you look at the variation, it's still the vaccine in the worst case is still has a level of efficacy that's well above the threshold that the FDA had set aside ahead of time. And secondly, that's the efficacy is against acquiring any infection. If you look at its efficacy against severe infection, it actually is significantly higher. So again, if we could get 70% of the population immunized with a vaccine that was even only 60% effective, we move so much further towards that might be enough to get life back to normal. So I'm not so fearful about what the variants are going to do with the immunized people. My worry is that the rate of spread with the variants, that people are going to relax with the good news. We're going to have variants coming in, and we're going to still have a lot of people who haven't been immunized, and we're going to see a big spike in cases because of the infectivity of the new variants, because we've relaxed our social distancing and all that. I'm less worried about a change in vaccine efficacy.
Yeah, I think that's incredibly well said. The only thing I would add is just that it's almost like a race, right? I mean, we have these variants that appear to be more effective, but at the same time, you have the vaccine rollout that's hopefully preventing these infections and preventing the spread of these infections. And so it's almost kind of like the faster we can get, and the more the population that we can get vaccinated, the less the virus chance to mutate because it's no longer spreading, right? And you're just suppressing the virus because of the vaccination rates and the herd immunity. And so it's, you kind of have two competing things that are happening actually right now, right? A virus that is changing, potentially getting more infectious, but you also have a vaccine rollout, which is really suppressing, starting to really suppress the cases, across the world and hopefully, obviously within the United States. And so there are kind of two things happening right now, but it does kind of lend the importance of, number one, getting vaccinated, but number two, making sure that we have enough doses to give to our population.
So there's a couple of questions I think that were in the chat right about the time I got kicked off that were really talking about once you are vaccinated. And I think Dr. Liu, you were in the midst of speaking of this. How long does the vaccination last? Should folks still wear a mask? Can you get the virus again even if you've been vaccinated? If we talk a little bit about that, what it means after you've had the doses or one dose, whichever regimen you're using when the Johnson & Johnson piece comes out and other types of vaccinations. So the 2 shots or the 1, whatever it might be, the chances of getting COVID again after you get that, should you still wear masks in the provisions? And then do we think that there's going to be the need to have a shot every year moving ahead for COVID, just like there is with flu? Just kind of talking about that sort of rollout from a public health and then how people should behave with their behaviors as well as vaccines in the future. Can you guys speak to that trajectory?
I mean, I do think that that everybody, vaccinated or not, needs to wear masks for the foreseeable future. So, because we have enough information to know that it's possible that you can carry the virus. There does appear to be a really high level of protection for individuals who have the vaccine. So the thing we don't know, and I think it's important to think about this, the first people who were actually immunized with these vaccines were immunized maybe in August. So we do not have a single immunized person who's 12 months after their immunization. So we just really don't know what it's going to look like. The thing I like to think in terms of analogous situations. So, no human being had ever been infected with this virus prior to its introduction, in somewhere in China last December. So we're all completely naive to it. If the entire world were immunized with it or exposed to it, I think it's going to look a lot like other endemic viruses. So, the truth of the matter is people are getting infected with coronaviruses all the time, and they get a cold. And very, very rarely one of those people might have a really severe reaction, end up in the ICU or on a ventilator. And that's usually when we figure out what they were infected with under normal circumstances. So this is me going out ahead of the science, but I think I think a year from now, if we've gotten really broad immunization, that the coronavirus is going to have a much lower case fatality rate and case severity rate than what we're seeing now, because of the fact that people are no longer immunologically naive to it. And even if we see some variation in it over time, which is what we see with most respiratory viruses. So, we've got a long list of respiratory viruses that circulate all the time, and they mutate and they change, which is the reason why, one of the reasons why you get, reinfected with something you had 5 or 6 years ago. But for the most part, they tend to cause much milder illnesses.
Okay. And then I want to go to, I know there's a question in the chat specifically around MIs and heart attacks, and then also in looking at neuropathy, which I think Dr. Ernest, we talked about ahead. Want to get to that one, but this other question kind of hinges a bit on what's been said, which I think is interesting. So I think the indication is if someone gets the COVID vaccine and the first shot, and actually between shot number 1 and shot number 2 actually ends up with a COVID diagnosis, should they get that second shot, or what does that look like? So we know again that first shot isn't giving 100% protection, but your second one and you get it, like, what a quagmire, what to do? Anybody?
I don't know how to answer that. There are, there are a series of case reports of people who got their first shot and then got infected within 7 or 8 days of it. It's actually, if you look at the trials, after 14 days after the first vaccine, there are not very many people who get sick after that. But the antibody level is low enough that the presumption of immunity is just not made with confidence. But gosh, how to deal with the, I mean, if you're in that situation, you are a pioneer. We just don't know, I don't think. So,
yeah, my guess is that they're still going to recommend the second dose, right? Because we just don't know any better. And there's no real reason to think that would be dangerous, but I agree with Mark. That's unique and hopefully will continue to be unique. But that does kind of bring home the point that it does take some time to build up antibodies. And so if you get the shot today, it doesn't mean that tomorrow you're fully protected, right?
Okay. And I know we're getting some questions in, and I want to apologize. When I got kicked off, it did clear out the feed. So I'm going back from memory, and I think there's 1 or 2 questions that that Christy's going to remind me. Okay, quick, because we have 3 minutes. There's 2 questions right now. Any known impact on complications with people with MIs or heart attacks? And I know we talked about MS patients. How about people with cardiac issues?
yeah, right now, I think if you have a diagnosis of any kind of heart disease, you should just consider that a risk factor, one of the two. And even if that was, 7 or 8 years ago, in terms of how much do you worry about this, I think the reality is everything sits on a spectrum. So if your cancer was 20 years ago and you've had no evidence of disease, biologically, your risk of COVID is probably not much different than somebody who hasn't had cancer, whereas somebody who's actively in treatment right now probably has a higher risk. For the purposes of prioritization, it's just way too difficult to try to draw lines along that continuum. So the way I'm dealing with it is if somebody has a problem on their problem list, if they've got heart disease on their problem list, even if it's old and not currently active, that's a risk factor. If they've got cancer or prior cancer in it, that's a risk factor. And so I don't think it serves anybody well to get too particular about parsing through those things.
Okay. And any known complications for people with existing neuropathy in legs and feet due to chemo, Dr. Liu?
No, again, we'll certainly get more data as time comes, but we have not seen any exacerbation of existing neuropathy. And, again, a lot of the neuropathy that's caused by chemotherapy is just kind of toxicity from the chemotherapy onto the nerves. And what we're talking about here with the vaccine is just honestly an immune response. And so it's really kind of hard to imagine that a vaccine that elicits an immune response against the coronavirus spike protein would then start attacking nerves. And that's a bit of a leap, in terms of the causality of that neuropathy. So yeah, for sure, a lot of our patients have pre-existing neuropathy from their prior chemotherapy treatments, should absolutely receive the COVID vaccine.
Okay, there's an interesting question that came through, and I think to that point around the immune response, the question is, does taking Tylenol, ibuprofen, or anything actually after the vaccine for side effects, does it blunt the immune response, or is there anything we should avoid just to negate the immune response?
So so there's no evidence that taking that for symptom relief changes the immune response in any way. There is I think a pretty weak guideline that says you're better off not to pre-treat. The one thing is probably, I don't know that really makes a difference either. If you have an option to, the steroids is one thing that's a little bit different. So people who are on steroids, which are known to blunt immune responses, should not change their dose. They should, if you're on a steroid, you should stay on a steroid. If taking a steroid is an optional thing as you approach it, and you're not chronically on it, I'd recommend you don't take the steroid. There are not many people in that situation, but that's the one place. And Chris, I don't know if you have disagree or?
Yeah, no, I completely agree. And, you are going to have some muscle aches after you get the vaccine, potentially. Some patients have just no side effects whatsoever, but should feel comfortable taking those medications.
Very good. I want to remind everybody your evaluation is in the chat. So the other question we have, and I want to give Evan some time here, and I know there's a few that have come in that we might have to actually entertain after. The vaccination guidelines require multiple comorbidities. What if it's this one patient with stage 1 or 2 cancer? When should they try to get vaccinated? I think, Mark, you had shared as quick as you can, any way that you can get on if you're so motivated. Every patient should. Anything else to add to that, Dr. Liu or Dr. Ernest?
No, I mean, I think obviously a history of cancer may improve your kind of standing in the priority list, but no, I mean, I would just say just get it when you can get it. But for a lot of our patients, it'll be actually more based off of age than it will be having that prior diagnosis.
Okay. What about the ACE inhibitors? That's our final question from Angela, I think, that has come through. Do we have anything about ACE inhibitors?
Yeah, so there was a lot of, this started as a theoretical concern because the coronavirus actually uses an ACE receptor to enter the cell. And so there was a question of being on an ACE inhibitor, does that modify your ACE receptors? And so early on, there was concern about that. I think as time has played out, it's clear that taking an ACE inhibitor does not put you at higher risk. There is some data, it's not the strongest, that would actually suggest it might be a little bit protective, and the degree to which if obviously ACE inhibitors co-vary with diabetes, they co-vary with heart disease, and people with those conditions are more likely to be on them. If there's any risk, it's actually not from the ACE inhibitor, it's from the condition that led to you to be on the ACE inhibitor. So, my recommendation to all my patients on ACE inhibitors is it's protecting you from a lot of stuff, and it ain't hurting you in terms of COVID. So, so stay on it.
All right. Well, this has been awesome. I know we're a couple minutes over. I'm getting some emails being summoned to somewhere else, just like I'm sure everyone else is right now. But I just want to say a huge thanks to Dr. Liu, Dr. Ernest. A huge thank you for Christy in the coalition for giving this format, and we will continue to keep these conversations moving. I think, Dr. Liu, you've been in every conversation that we've had about COVID, so you're sort of our, but Mark and Dr. Ernest, your expertise and input in terms of the work of the coalition is much appreciated, both of you. Christy's put the chat, the evaluation for today, and then ultimately the coalition's website if you have further questions that didn't get answered today. So have a great day, everyone. Stay safe, stay well, and a million thanks for everyone for all of your efforts, and really appreciate all of the great info. Have a good afternoon, everyone.
Thanks, everybody.
Bye.
Bye-bye.